So good morning, everyone. I am Christy Paleman, your host. I wanted to let you all know of a couple of changes with my role at the moment. As you can see, I'm wearing a Yukon sweatshirt. I've become a Yukon Husky, and I am in graduate school. And so last semester, I worked full-time, found it a little bit intense, and so this semester I've dropped my hours to 32. And what that means is for Wednesdays and Fridays, I'll be working half days in the mornings only, and I'll be going up to class for the afternoon. So if you have any questions, you can still email me. You can use my cell phone. And I will try and get back to you as quickly as I can. So just letting you know a little bit of a change in terms of my schedule. A couple of other things that we have in the pipeline for you, especially for the nursing team and the SASH coordinators, this does affect you as well. I am working on the 2017 blood pressure guidelines, and we'll have new training content that will be provided to you via webinar in March and April. Right now, I'm planning on offering like multiple webinars. The training I'm trying to keep down to an hour, and so that will be the format that will do that, and you can like sign up for the webinar that is most convenient for you. The other thing that we have, the other topic we have in the pipeline is we received some grant monies to move forth with the diabetes training initiative, and we're working with Jill Robart, who's a wellness nurse down in Bennington, and she's a certified diabetes educator, so she's our subject matter expert for sure. And Jill is going to be providing live trainings to the southern part of the state in May and June. We're going to record that. I'm not entirely certain how we're going to get the northern half of the state trained yet, but we'll put that plan in place, and I'll keep you posted. That'll be the Chittenden DRO, the Central Vermont DRO, and the Northeast Kingdom DRO. So if you fall into those areas of the state, just stay tuned. You will get the information, but it might be more like July and August timeframe. And go to the next slide, please. We have a case study today that was developed by one of our colleagues, Hillary Adams. Hillary is the SASH wellness nurse with the Rural Edge panels. She literally works, I want to say, like a stone's throw from the Canadian border. So she is way up north working with a couple of panels up there. Hillary is on Facebook every morning doing public service announcements. I swear that's what they're called, reminding everybody to wash your hands, WYH. And Hillary provided the case study for today. So I want to thank her for that. We also have a case, not case study, but clinical vignettes that were provided by Lisa Pate and Emily Hood Pulio. And I want to thank them. If we get time to go through all of those are the people that were responsible for pulling those together. So next slide, please. So I want to introduce our speaker for today, who is Julie Parker. And Julie comes to us from Northwestern Counseling and Support Services. I'm going to let Julie introduce herself a little bit, and she will then get on to the content of our webinar.
Okay, good morning, everyone. Thanks so much for inviting me to do this. I want to be honest that I've never actually done a webinar without seeing people's faces, so that's a little bit of a challenge for me since I'm a relationalist type of therapist. So I'm going to do the best I can not seeing all of your lovely faces out there this morning. But I've worked in community mental health for over 22 years. Right now I oversee our integrated health team, which is our social workers who are out of primary care. I oversee our outpatient therapy team, and I also oversee our crisis team. So I have lots of different roles, but I love what I do and happy to be here today. So I can just jump right in if that's ready. So our goal today is we're going to talk a little bit about depression and how we can help. I want to familiarize everyone with different types of depression, how to recognize them, understanding some differences across the lifespan, treatment options, how we can help. And I don't feel like we can talk about depression without addressing suicide, and we'll touch on anxiety a little bit as well. So I've got a lot of slides. I'm going to try to go through them as clearly as I can. I hope I'm not speaking too fast. Let me know if I am, and we'll proceed. I wanted to share some common myths about depression. I think there's still a lot of stigma in our society, and I think in the roles that we're in, it's part of our responsibility to challenge that. You know, I hear a lot from folks we serve that, you know, being depressed is a sign of weakness. It's a normal part of aging. I can figure it out myself. I can handle it. I don't need help. I don't need to talk to anyone about it. It's not a health problem. I can just tough this out. And those are some myths about depression. And I think, as I said, the more we can debunk some of those, I think the more folks will access services and treatment and recognize that depression and mental health issues are just as valid as any type of physical health issues. So I view that as part of all of our roles in the community and talking about that more openly and freely. Not just depressed, they're lazy, and people need to snap out of it. So just some basic depression facts. In 2016, data showed 10.3 million U.S. adults ages 18 or older had one major depressive disorder. Twice as many women are diagnosed with clinical depression, and the suicide rate among older adults is actually 50% higher than the national population, which we'll talk a little bit more about some statistics later that are pretty shocking around suicide rates among adults. So there's different types of depression. We have major depression, dysthymia, bipolar disorder, and then we'll touch on some other types of depression as we go forward. So what is a major depression? So this is the most common form of a depressive illness. It really involves our whole body. It impacts the way we work, we study, we sleep, we eat, or the ability or inability to enjoy pleasurable activities. Not everyone who is depressed is going to have every single one of those symptoms. When diagnosing depression, severity and frequency are really key. And disabling episode of depression may occur only once, but can occur several times in a lifetime as well. So according to the DSM, in order to diagnose someone with depression, you're going to have 5 or more of these in a 2-week period. Persistent sad, anxious feelings, loss of pleasure in activities, frequent feelings of guilt, worthlessness, hopelessness, a decrease in energy, appetite or weight changes, sleep issues, issues with thinking, concentrating, crying, restlessness, irritability, aches, pain, suicide, or wishing you were dead. So those are typically when, you know, a clinician is doing an assessment or a psychiatrist is doing an assessment. We're really looking at those specific symptoms. We're looking to see if there's 5 over those 2-week period of time for a depressive episode. So dysthymia is a longer-term chronic depressive situation. It keeps somebody from functioning well, but it's not as severe as a major depression. So it might not be 5 out of those symptoms we talked about for 2 weeks, but maybe a few of them, but just more ongoing. Someone with dysthymia could have a major depressive episode in their life, but they're kind of more just like, I have 2 little graphics there, Eeyore, where things just always seem a little bit blue. And this other little graphic says, cows can sleep standing up, lucky them. So just, you know, a general feeling of sadness or maybe issues with sleep, low self-esteem, just something that folks can't choose but continue for a period of time, more than the 2 weeks. Bipolar disorder is a type of depression. It's also called manic depressive illness. So there's 2 types of bipolar disorder. Bipolar 1, which has manic episodes that last 7 days and can also couple with some depressive symptoms. Bipolar 2 is depressive symptoms with bursts of energy known as hypomania, and I'll talk about those on the next slide, but not a full-blown manic episode. It's not nearly as prevalent as other forms of depression. Bipolar disorder is characterized by cycling moods. There's some severe highs and very low lows. Sometimes the moods are dramatic and rapid, but most of the time they're gradual. So you might see somebody, and we'll talk about it, you know, that is maybe spending more money, making risky decisions, not thinking clearly, having grandiose thoughts, and it happens kind of slowly. And then when in the depressed cycle, they can have all those symptoms of the depressive disorder that we spoke about on the previous slide. I think a lot of times, we might find folks that will say they have borderline personality disorder versus a depressive depressive disorder. And they can look very similar to bipolar, but similar to have the mood swings, uncertainty about how they see themselves and their role in the world. They have intense emotional states for relationships and difficulty returning to calm. But a true bipolar disorder is very different than someone struggling with borderline personality disorder. So if there are questions on that later, I can address those. So symptoms of mania, and what's also called hypomania, there's sort of a spectrum of how intense these symptoms can be, but if there's, inappropriate elation, irritability, severe insomnia, like days without any sleep at all, but they can still function, grandiose thinking, I found a cure for cancer, they're very grandiose ideas that may be based in some reality, but not exactly. Lots and lots of talking, increased sexual desire, disconnected or racing thoughts, lots and lots of energy, hence the lack of sleep, making poor judgments, so they might go out and buy a car, spend money, and inappropriate social behavior, just inability to sort of see boundaries are some signs of mania. And so hypomania are pieces of those things, but maybe not as extreme. Other depressive disorders that we have, seasonal affective disorder, same symptoms as a major depression, but at certain times of the year, it's usually late fall and winter, and I think we can all get to that feeling where we just need to see some sunshine. When spring arrives, usually people's energy returns, symptoms dissipate, and at times it's successfully treated with light therapy. We have some light therapy boxes we rent out to clients, or rather let them borrow, and that seems to help folks as well. But, getting out and getting some sunshine on the days we have it is really important. Postpartum depression, same criteria of major depression, onset usually within 4 weeks of giving birth. A lot of times, people just chalk it up to baby blues, and we know that it's more than just having the baby blues. So it's important to really talk to new moms about how they're feeling, the support, and to really, again, break down that stigma and normalize if they're having difficult feelings and wanting to talk to someone or get support. I want to touch on depression in children. Depression in children can manifest itself in different ways. Certainly a child can seem sad, but there are other ways to make sure we're addressing children's mood changes. If we're seeing lack of energy, difficulty in sleeping or sleeping too much, this might be above and beyond the teenagers who can sleep for, 13 hours at a time. Children may not report that they feel sad, or they can't always put labels to those emotions. But rather they might use, other words like feeling ugly or stupid or worthless. They may feel guilty or worried a lot of the time. They may act out in school with temper tantrums or use substances or may, engage in suicide attempts or self-harming behavior. So I think it's really asking a lot of questions about home environment, school environment, peer environment, but it may not manifest itself in the same way as it does in adults. Children definitely respond well to treatment. They don't have all of their coping skills entrenched yet, so we're able to support kiddos and being able to acknowledge, some stressors and how they might handle those. Therapy is often effective with kiddos. So it's important to, work with providers who really are comfortable with those age groups and engaging with kids and teens in different ways. Typically, they're just coming into a session, sitting for an hour and talking, like therapy and different strategies to engage with teens and kids. Certainly, the family is a big factor in supporting that as well. Lots of risk factors for kids right now in terms of peers, bullying. We know social media is a big stressor, gender identity issues. Those are all things that can certainly increase depression in children and teens. So keeping your eye on those things, asking what's going on in school. Touching on depression and aging. So symptoms can be the same, but it can be more difficult to assess. We use different terms or language. I always make this kind of correlation. My grandma would always say she has to take her nerve pills. So I never really understood what that mean. And then my mom kind of explained, it's anxiety, or grandma suffers with depression. And so there might just be different terms for folks to talk about what they might be feeling. Cultural differences, generational differences can be barriers to treatment. Symptoms of memory impairment, slowed movements could be easily confused for, a stroke or becoming senile or Alzheimer's or things like that. What I think is interesting is I don't think that depression is a normal part of aging, and I think a lot of times I hear people say that, well, they're getting older, they don't feel like they're as involved in things, and I think that can be true. But I also think that if you think of any of us as we age, our coping skills actually get better. We know what are triggers for us. We know how to, most of the time, support ourselves, reach out for help, those kinds of things. So I do think that when folks say that, I do try to challenge that a lot and just say, let's think about that a little bit more. We know as, folks age or elders that life events can often be the precipitants of increase in depression. So poor health, loss of a loved one, loss of independence can all be really challenging. That feeling of, feeling useless, isolated, or alone, which can increase their vulnerability to depression. So can be a mixed bag there. So important to really assess again and talk about what may be going on for someone. Other factors generally to consider: medical conditions that cause depression, neurological disorder, thyroid disorders. My mom has a serious thyroid disorder that was undiagnosed for a long period of time, and we were unclear of really what was going on. So in that case, it was really helpful to have a full medical workup and understand what was happening and get her on medication that was supportive for that, but that did cause some depression. And so I'm always one to say making sure that you are encouraging clients to, get medical workups. Are their medications correct? Those kinds of things. Dementia, Alzheimer's, MS, epilepsy, cerebral trauma, vitamin deficiency, substance abuse, cancer, all those things are going to be factors at any age for folks who might struggle with depression a little bit more, factors to consider. I want to just touch on trauma. Traumatic events or, any instances where someone might witness a trauma or perceive to be a threat of their life. So accidents, assaults, mass events. We had one this week in Florida, unfortunately. People differ in how they react to trauma. Some people can suffer from depressive symptoms, post-traumatic stress. Other folks can go into helping mode and may not impact them as much, but really asking folks about the trauma in their lives. And it can be recent or it could be in the past, and that might impact their depression. Folks with a diagnosis of mental illness, especially those who've been traumatized in the past, are at increased risk for serious reactions to trauma and ongoing depression. So I always call depression and anxiety a power couple because a lot of times I find that depression and anxiety go hand in hand. What comes first, the chicken or the egg? Sometimes people have a lot of anxiety and that causes them to feel depressed. Some folks feel a lot of depression and that makes them, feel anxious. So a lot of times you may see symptoms of both. And anxiety disorders, they're different from just normal stress and anxiety. We all have a little bit of stress and anxiety. Did I leave the curling iron on? Or I'm worried about paying a bill. And this is really above and beyond that. And it really can exacerbate the depression. So this little picture just shows all the symptoms folks can have when they're struggling with anxiety. Just, those physical sensations and mind racing and different things that just make folks feel really uncomfortable and may isolate more, which could cause depression. So what does cause depression? So, there's been a lot of research on depression and a lot of looking at the different components. Is it biological, psychological, social? Is it a genetic predisposition? We know that they can be triggered by stress, difficult life situations, the things we talked about. So, I think it's a combination of a lot of things, but definitely we can have a predisposition to having depressive symptoms, especially if we have a history of mental health issues in our family. So, keeping aware of that, or when you're speaking with someone, or if you're doing an assessment, to ask someone, does your family have a history of depression? Do you know of anyone in your family that has mental health issues? So how is depression diagnosed? So we recommend a physical examination, as I talked about, by a doctor to rule out issues. A psychosocial evaluation where we ask about history of symptoms, family history, suicidal thoughts, use of drugs or alcohol, mental status to determine any thoughts, speech or memory impairment. So that's kind of the first out of the gate, asking folks about that. So people often ask why they should seek treatment for depression. And honestly, I say because it's treatable. Seeking treatment early may help the illness from becoming chronic and severe, helping folks gain skills and have a greater understanding of what are triggers for them, or what they might be predisposed to if this isn't a specific event that's caused the depression. We really feel that the best treatment is a combination of psychotherapy and medications. There's been really successful studies about medication on depression, but overall, psychotherapy and support are really recommended more than the medication. Again, I don't want to minimize medication. It has its place, certainly helps folks quite a bit, but really that level of support and understanding through psychotherapy or other supports within the home, et cetera, are really ways to help boost the mood and challenge the depressive symptoms. So the medication can help relieve the symptoms, and the psychotherapy can help the coping. So, I'm not a doctor. I'll just touch on this briefly, but we know there's key neurotransmitters. We know that they're not kind of hooking up as effectively as we'd like them to, and that can cause depression. So SSRIs, selective serotonin reuptake inhibitors, are usually the first line of defense in terms of prescribing, and those are typically Prozac, Paxil, Zoloft, Lexa, Lexapro, those kinds of things. If folks feel like medications aren't working, we may look at the diagnosis. We may find that meds are not that, again, effective, and just all the other complicating factors that happen in our human lives that impact our mood daily. So just, really looking at those things. Side effects to meds. Some people, are really sensitive to side effects. Sometimes they can cause, dry mouth, dizziness, weight gain, sexual dysfunction, blurred vision, and nausea. So at times people won't give it a full trial because they don't like the side effects. But, much like anything else, you could, if you felt like there are positives or your mood's changing, you may say it's worth having some side effects for the game. ECT, electroconvulsive therapy, it is still something that is done, and it is effective for folks with severe depression. It's not something we would start with right off, but it definitely is something that still happens. UVM Medical Center does it here in the Burlington area. There are some more significant side effects such as memory loss, confusion, and disorientation for periods of time afterwards. But with really severe depression, it definitely has been shown to help, and we do make some referrals for that. So how can you help? So I think one of the key things is listening, non-judgmentally. I think really being open to accepting where the client's at, having empathy, showing your nonverbal skills, being attentive, that eye contact, open body posture, sitting next to the person, not fidgeting, not seeing that you're feeling bothered to be hearing about the situation. I think helping someone to get appropriate diagnosis and treatment is really key, offering that emotional support. As we talked about, encouraging families to offer support, encouraging folks to stay in treatment, especially as I mentioned about the medication. A lot of times people will try to take it in 2 days and will say, oh, it didn't work, it's not working for me. So really give it a full chance for the medication to work, really staying in therapy or accessing support, not accusing the person of faking it, encouraging families, not to say things like snap out of it, pull yourself up by bootstraps. I don't think any time those are helpful. I think working closely with a client's treatment team and their family around what's everyone's role, how can we support this person. Take the concern seriously. We'll talk a little bit more when we get to suicide about that. But really, again, just listening to those. I think the other key thing is, really maintaining the relationship you have with the person and not treating them as fragile, and that can be really difficult when someone is struggling. So you may need help, a person make an appointment. If they're struggling with depression, it might be hard for them to make that initial call. They may need somebody to accompany them to counseling, maybe get the ball rolling, meet with the counselor and just say, this is what's happening, and help kind of, assist the person getting out what's happening. They may need their medication monitored, following doctor's requests, and that's not just, depression medication, that's also physical health medication, because there is a correlation with that, making sure they're taking that, making sure blood sugar is where it needs to be, all those things that, physical and mental health merge together and make us feel better when we're doing all the things we need to be doing. Exercising, getting fresh air, all those things can be helpful. Offering hope, pointing out realities. Sometimes when working with folks, it is helpful to sort of do that social comparison to say, like, yes, things are really difficult, but you are lucky you have kids, or you have this, or you have that. And sometimes that really can help someone see that there is some positives going on, so that can be supportive. Encourage the person to do some social events and enjoyable activities that they like to do. Make sure that any suicidal information is going to the person's team. So suicide in America, I just think this is always very startling to me, and I think it's really important to talk about. So especially in Vermont, we actually have a very high incidence of suicide. It's the 8th leading cause of death in Vermont. 2nd leading cause of death in Vermont, ages 15 to 34. 4th leading cause of death, 35 to 54. 5th leading cause, 55 to 64. And over six many more people die in Vermont by suicide than the national average. So I think that's pretty startling, pretty concerning. Part of it could be we're not talking about suicide enough. We're not talking about mental health enough. There's still stigma attached to suicide, mental health issues, accessing help, all those things. So like I said, for me, that's a pretty startling number that in our state, that's the 8th leading cause of death. So, and 11th leading cause nationally, one suicide every 16 minutes, one attempt per minute. Equates to 80 people a day, 1,500 attempts, and this is from the National Center of Health Statistics. Suicide in America for elderly. So we know that the rates rise for men significantly after age 65, more than women. 60% of elderly patients that have completed suicide have actually seen their PCP within a couple months of the suicide. And we know this for a lot of different things as well. A lot of times people will go to their primary care and they'll talk about some physical health issues, but won't touch on the mental health. And I think, one of the things we're doing across the state, which I think is so wonderful, is really embedding folks, having SASH folks, asking the PHQ questions and the other screening tools that we have, so that we're able to really put those questions out there and assess them with the other questions we're asking. What's going on physically? Hey, let me ask you some questions about substance abuse, and also, any mood changes or anything like that. So, suicide and firearms, 83% of deaths in homes that own a firearm are usually by someone other than the gun owner, which indicates really talking to folks about, making sure family is locking up guns, locking up things that are dangerous. They're used more in suicides than homicides, 60% of all suicides by firearms, and it's the fastest growing method of suicide. So risk factors for suicide: gender, we know males over a certain age have a higher risk, age, physical illness, mental illness, alcohol and substances, less social support, previous attempts, organized plans are all risk factors. We really encourage folks to ask about suicidal thoughts and ideation. A lot of times we find people are worried to ask questions about that, and as providers, and then in the end, folks are really relieved because it's on their mind and they do want to talk about it. Asking if someone has a plan, do they have means, do they have a history of attempts, do they have the intent to kill themselves, or do they just want to get out of perceived pain? Are there any deterrents? Are there other high-risk behaviors? We find if people are creating closure or making amends for things, that can be a concerning sign. So there's lots of resources out there, and so I just put some on this slide that you could look into. NAMI, other local, folks you can consult with. I think everyone knows this, but I'll just say it in case they don't. There's 10 designated mental health agencies in the state of Vermont. So every county has a designated mental health agency with crisis services 24 hours a day. So for Franklin Grand Isle, that's Northwestern Counseling and Support Services. And I've listed the other ones just because I thought that might be helpful in case you didn't know. There's always Vermont 211, and there's certainly a support with resources, et cetera, Veterans Crisis Line, Suicide Prevention Line. And yeah, so that's the end of my talk, and I'm open to questions or thoughts, and then I know we have some case studies we wanted to talk about as well.
Great. Thanks so much, Julie. Can you hear me okay?
I can, yep.
Good, because I unmuted myself. Does anybody have any questions? If you want to type them into the chat, that would be great. Any questions for Julie at the moment? And if not, I'll jump into our case study and we can have a little discussion about that. All right. If there's no questions, so this is Hillary's case study. Oh, and we've got actually, I'm going to ask one question. Allison says, thank you, Julie. Just wanted to let you know that the first call now covers children and adults, all individuals with Chittenden County.
Oh, perfect. You know what? You're right. I do know that, and we need to update that slide. So thank you for the reminder. I will do that.
Great. Thanks. Thanks so much, Allison. So let's talk about our case study a little bit, and maybe there's a few words of wisdom Julie has, and if you have any questions, let us know. We have a 73-year-old female. She lives in an apartment. She has multiple chronic conditions, and I don't think that this would be a surprise to any of you. This might seem like a typical SASH participant. This participant does have diagnosed depressive disorder and anxiety. She is a type 2 diabetic, has chronic pain, insomnia, some memory loss as well, hypertension, cirrhosis, small vessel ischemic disease. She's obese, has high lipids, sleep apnea, and has a history of a head injury. And I think you mentioned some of those in your previous slides. So quite a few issues to deal with this person. Lots of medications to manage her diabetes, her breathing issues, as well as some pain medications as well. And let's see, she is, I think we can go to the next slide. I don't think she's on an antidepressant yet at this point. So she's known the SASH team for 2 years, and as Hillary would describe it, they've been chipping away at the issues. She is a chronic care initiative SASH participant, so she does have a chronic care coordinator involved. And one of the biggest issues that the team was dealing with initially was this history of very high blood sugars, 300 to 400 was the blood sugars. And Hillary became involved in performing weekly wellness nurse visits, basically. Interestingly enough, Hillary is also a diabetes self-management program, the Stanford Healthier Living with Diabetes program. She's a trained leader. So Hillary was trying to coax this gal to come and participate in the DSMP classes, and she finally did join. It was their second attempt at trying to get her to come and join. And the team then was able to provide this medication support for her diabetes, and she had a med change. So she discontinued her Novolog and started on Victoza, and they were able to bring blood sugars down into the 200s, which was a significant improvement. And as her blood sugar came down, her blood pressure also seemed to come down. In terms of mental health, very depressed. She has issues with her family, that her daughter, as you can see, suffers from bipolar disorder. There's grandchildren involved. When the daughter has an exacerbation of her mental illness, the participant does as well, and this leads to her having an exacerbation of her anxiety and depression. So complex family issues that are really as we see very typically when we have these complex family issues and family dynamics, that those may become something that is, it really is a stumbling block for a participant that is already dealing with complex medical issues such as diabetes. It's really difficult to manage that disease process in and of itself. Add to it then a stress to the situation, and we know that blood sugars will literally go all over the place. So the SASH team intervention, Hillary, bless her heart, had been pretty much a broken record about getting behavioral health involved and working through the primary care office. And the PCP did complete that referral, but the participant did not attend that appointment with behavioral health until October. And now is seeing a behavioral health, as you can see, therapist every 2 weeks, unless she cancels or has a scheduling issue. And Carol asked, where is the chronic care coordinator from? And Carol, all that I can tell you is this is Northeast Kingdom. So I don't know exactly where the coordinator is from, but the coordinator is an RN, and Hillary and the coordinator alternate weeks of visits, so that, you know, one nurse is seeing the participant every week. So great collaboration there, I would say, on the team's part. She obviously has primary care quite involved and willing to help her out. What's really great is because she attended the DSMP class, she has fantastic peer support in place now. So she has folks in her building that are also managing diabetes and able to provide her some support. And the behavioral health counselor, that's recent, and so she's seeing that therapist, as we said, every 2 weeks unless she cancels or has a scheduling issue. So, Julie, I think with this case, is there anything, you know, additional? It seems like the team has really kind of come full circle, and as I said, you know, Hillary had been chipping away, and the entire team basically had been chipping away on working with this participant to really try and get, you know, multiple health issues, mental health issues, as well as the issues with diabetes, which then exacerbate blood pressure, and then, you know, you have the whole, you know, cascade of things. She probably has metabolic syndrome going on as well. But any other suggestions that you would consider with this participant in terms of approach or services that maybe the team hasn't thought of?
Gosh, this is really, I mean, I'm impressed with all of the services, and I was going to talk about the peer support, and that seems like it's newer. That's exactly what I was going to ask. You know, who does she have for natural supports was definitely one of my questions, and how does that engagement go?
Yeah, I think the peer support in her building, so that was the summer of 2017 when she attended the diabetes self-management program. And as many of the folks on the phone can tell you, that we have a lot of leaders in SASH for those healthier living with chronic disease, diabetes, and we do a pain class as well. And you know, that's new. So hopefully when our staff are providing classes, it's within either the buildings that they're working in or within at least the community that they're working in. So hopefully there's some ability to build those peers as well. And I don't know if Hillary's on, if she wants to say anything more about that. I can unmute you, Hillary, if you want to talk. Hold on one second. There you go. So Hillary, you're unmuted. I don't know if there's any further family support that this gal has in place.
She's really resistant to outside help. And I've tried getting her to, there's a really good substance abuse community in Newport, and she drives, and she's just really reluctant. So, you know, we've done everything we can, and we just do, you know, support as we can. And again, some days are better than others. You know, it's the way it is.
Has she ever been to, has she ever been to a WRAP group, the Wellness Recovery Action Planning?
Well, that's what I've been trying to get her to for about 6 months, and she has not any interest at all, none. And no matter what information, I've even dialed the phone for her, and she just won't do it. And she's got a lot of resistance to that, and I'm not really sure where that's coming from, other than it's private, and there's other issues within that family dynamic that I think she's worried about.
So let me go back a second, because you just mentioned something about substance abuse, but I don't see that on here. Is that the daughter?
Yes.
Okay, yep. The daughter has substance abuse issues. Okay.
Right.
Yeah, and so is the depression really based around situational things with her daughter? Like, does she worry about her daughter being able to provide care for the kids?
Right.
Does she
right.
take on the babysitting or childcare?
Again, the children were taken away from the daughter quite a while ago. I think it's the second time, and so she does some babysitting. The other grandmother does, I believe, has custody, and it's a really messy situation, and she struggles very much with. She feels guilty because of the daughter's issues. Again, she doesn't always keep her appointments with behavioral health, so that that understanding part, or learning to understand that, or lose the guilt thing, just it's a struggle.
Yeah. Well, and I wonder also sometimes, I question, when folks see a therapist, sometimes the therapist brings up tough stuff, and then it's hard to sit with, and they don't go back, or they miss appointments,
right?
Because they know they're going to address some difficult things, so that's hard.
Right.
There's two other things I wondered about. In terms of the RAP group, it's just about, does she know her own triggers? Does she know how to cope with them? And I like the RAP group.
Nope. She doesn't know any of that.
Yeah. She can really make a plan around that, whether someone uses it or not. But I find it's a tool. Then that way they have, my client will have a RAP plan, the Wellness Recovery Action Plan, and then you have a copy and you say, remember, we talked about these are the skills to use when you're starting to feel concerned about your daughter or whatever. So it feels more cohesive and collaborative that that you're on the same page with that. But it's hard to get folks to commit to going, for sure. And then in terms of her diabetes, gosh, that certainly has to impact her mood. So is she willing to work with like a nutritionist, or do you feel like she has an understanding of what makes her blood sugars go high?
She actually does. She's very knowledgeable. The hard part is, I think, well, from my point of view, I think her depression really is based metabolically, but also as soon as that kicks in, she stops eating well. She stops self-care, and a lot of times we go back to step one. We go right back to the beginning. So yeah, she's real knowledgeable. She really liked the book with the diabetes self-management training. She will refer back to that a lot because
great.
She does have some memory issues, so we talk about the diet again, and she also, when she's really eating well, she has a sister that will come and help her, sometimes maybe twice a year, not often, or if she goes to her sister's, when she's eating well, she's a million times better, but she won't always do that for herself. So it's it's that whole cycle thing.
Sure.
This is Christy. I'm wondering, Julie and Hillary, if maybe the behavioral therapist would be willing to put a RAP together for her.
Ooh,
one-on-one.
Yeah.
Absolutely. I think that's a great idea. And even
if
they're doing RAP, they could still put a plan, a real kind of cognitive behavioral plan in place, and then share that with the team to say, we all want to support you on these goals and know your triggers, so we can say, X, Y, and Z. Yeah.
Right.
And then,
and so with the chronic care coordinator and yourself, then at least you guys, like, every week would be, in sync of, what's the plan? How are you doing with it? Like Julie said, what are your triggers? How are you managing your triggers? That might be a little bit helpful. I know that we did that with one participant who lived in a very rural area, and she was seeing Howard Mental Health in Chittenden County, and we did, the therapist did a RAP with her that it sat on her coffee table, and it was a little book, a little handmade booklet that we all could utilize. Hillary, while I've got you, do you know, Carol had asked, where is the chronic care coordinator from?
She works out of North Country Primary Care, and she works out of Newport as well as the Barton Clinic.
Okay, thanks so much.
Yep.
How much do you feel like she gets around or moves around? Like at our hospital, we have a great group. It's like, I can't remember, it's like Healthy Women Stay Strong or something, and it's for older, I think it's just a female group right now, but like they do different things where they hold onto chairs, but do like little leg lifts and do really small weights, and just, it's really modified for folks, but just really moves your body a little bit more. And I just wonder if she, gets outside or those kinds of things, just other physical things that can, lift your mood a little.
That depends on her mood, and it depends on motivation. Often, if her grandsons need something, she is out the door and doing. Other times, not. And again, I do believe that part of it is blood sugar and part of it is depression. So if her blood pressure is doing pretty well, she's more apt to be, wanting to do it. I'll put it that way.
Yeah,
so it
that
depends.
makes sense.
It's very cyclical or cyclical. I mean, she's really a tough cookie because she doesn't maintain consistently, and so between the chronic care coordinator and I, we plug away.
Yeah. Okay. 7. Yep. Okay.
Does anybody else have any questions for Hillary or Julie while we're on this case study? You can type them in the chat. If you raise your hand, I will unmute you. All right. Hillary, great case study.
Oh, thanks.
Yeah, you guys are doing an amazing job. And I think the other thing I would say is just making sure that the whole team is communicating, especially with the therapist overall, so you kind of all know what's happening and, that there's no, for lack of a better word, splitting, just that everybody kind of knows what everybody's working on, what the recent stressors are, and everybody can be, working on in the same lane. So that's awesome.
Yeah.
Right.
Yeah. And
Hillary, the chronic care
ahead.
coordinator and I are usually in touch once a week, generally. So, and she keeps the behavioral person pretty well up to date. It's all we can do. I mean, I only work 20 hours, so it's, slipping it in when I can.
Right. And who's your coordinator with this participant?
Danielle Greenwood.
Okay, great. Good team. Very good. Nice. Thank you. Thanks a bunch. And yes, great work. Good work you're doing here.
Okay, thanks.
We can go over to the clinical vignettes. We have a few minutes. So these came in from the field. These are from my former SASH coordinators, Lisa Pade and Emily Hood-Pulio. And the first one, and these are probably really typical of what we see with folks. The first one is a 75-year-old man he doesn't drive. He walks everywhere. He's had significant losses within the past year. Mother, younger brother. He self-medicates with non-prescription substances. I will leave it at that. He suffers in silence and will not accept a suggestion for counseling or even discussion with the primary care provider. So the question from this coordinator and the wellness nurses are really, what are some approaches that we can take with folks like this? We see quite a few who are no, I'm not going to go and seek help, but they're willing to open the conversation with us. And are there approaches that we could take, Julie, that you could suggest, with that to maybe move them in that direction?
In terms of the self-medication, though, is this a new thing or a life thing?
It's a chronic.
Yeah.
Not new, chronic.
Not new, it's chronic. Okay,
yes.
Okay. So it sounds like, that's his coping skill for dealing with difficult emotions and things that are going on for him. So when you say that he walks everywhere, does he like to walk?
Yes. He does. Very, I'd say, in shape in terms of, activity level and as a walker. He'll walk to the local stores and this is out in a rural area.
Yeah, that's great. Obviously, I'm hoping someone's having a conversation with him about the use of substances, but it sounds like that might be challenging and maybe why he's worried about talking about it more because people are probably going to suggest he decreases his use of substances. I wonder with him, maybe he does feel like he might need some more of a purpose. And so I just wonder if would he be a guy that would be willing to do a walking group with folks, something to boost his own, he obviously, had a loss. Two big losses this year, and maybe I don't know if he's the kind of fellow that likes helping others and would be engaged with something like that.
Yeah, that's a good idea.
it out more. And then I just wonder, you know, it's hard. I mean, sometimes we don't use the word counseling, we use the word wellness coach. I don't know, sometimes when we change the terminology that helps people, it makes them not feel like, you know, I need counseling, I'm broken, or, you know, something like that. So that might help as well. But I definitely think when we talked earlier about the generational stuff, I think this is a good example of probably someone that, you know, at 75, you know, people didn't talk about depression, people didn't address those topics. So it might be very difficult you may have to find some different language that can hook him, is what I might find in knowing him. You know, I need to kind of get to know him, but there are other ways to hook him for sure.
You know, using different language, I think, is a good idea, a different way of presenting, because you're right, counseling, sometimes people are just like, they immediately shut down when you use that word.
The other thing I thought of real quick, sorry, is just that if the person in the PCP office or the counselor was willing to walk with him, a lot of times I find with folks in this age range, they cannot sit in a room and tolerate eye contact. And so, you know, even if they come in, like, I'll see folks walking around the building with people, and, you know, it's that side to side versus that direct eye contact that feels more casual. And I find that helps a lot as well, as an aside.
Oh, good one. I like that. Yeah, I just actually read an article about go for a walk. It was go for a walk with your primary care provider.
Yeah.
For multiple reasons. And mental health is one of them. Yeah. Okay, vignette number 2, 78-year-old man lost his wife in March 2017. Son is involved in the situation. And the SASH team is questioning, do we have a memory issue versus depression, or both? You know, could definitely be both. So not eating quite well, losing weight, has had UTIs. An elder care clinician referral has been made, and he may have been seen by now. And the team has been informing the primary care, but the biggest issue is the son is completely in denial of the problem, that there's either, you know, memory versus depression issue or both. And the team was interested in strategies on how to work with the son to kind of pull him into the fold of you know, being part of the team, whereas right now he's, you know, dad's fine, everything's fine.
So there must be a release for son.
Yes, there is.
You know, I would try to have a conversation with probably the son one-on-one if possible, or if this is, I guess, is the client worried about himself? Is the participant worried enough to be able to even have a family meeting to say, you know, hey son, I am kind of worried about myself. This is what I need from you. I don't know if it could go in that direction, but if not, I might have a conversation with the son. I mean, my guess is, you know, if he just lost his mom, the thought of losing another parent most likely is pretty scary. So the level of denial is probably, you know, his way of coping, to be like, I can't lose another parent. I just lost my mom. My dad's fine. It's okay. Things are fine. So that could be his own dynamic. And so, you know, even if somebody could acknowledge that to him, like, must be really hard. You just lost your mom, and now, you know, we're telling you we're worried about your dad. Like, that's really difficult. So,
right.
I'm concerned about the UTI and that obviously impacting his memory. Why are there frequent UTIs? I guess, you know, because that could absolutely be the memory stuff versus actually having memory, as we all know that can do. And then I guess just in terms of the nutritional stuff, like, could this guy, does he get Meals on Wheels? Does he not like to eat? Is he having physical stuff that he's not talking about? That's another thing I find. You know, some folks don't want to talk about their physical issues, but maybe they're having acid reflux, or maybe they're vomiting, or maybe having diarrhea, or different things. So they're avoiding eating for those secondary symptoms, and really it just might be they're getting older and they have IBS, you know? So I talk about that a little bit more, because or it could just be he doesn't like to eat. Who knows, right?
Right. So maybe a team meeting, it sounds like. I like that idea a lot.
I think so. Yeah.
Yeah, I'm trying to pull the son in and seeing if the participant can also, you know.
You're hoping to touch base with
and maybe having a one-on-one talk.
I've got somebody else talking on the phone here. I can hear. I'm going to mute somebody else here. There we go. Okay. Sorry.
Okay. Well, yeah, I would assume he's on his way. It's just about 5 minutes until your scheduled time.
Somebody, I can still hear you talking. Let's see if it shows up.
Okay. And Is there a
that
reason
person.
that you're not able to meet with him today?
I don't know. Okay, so I'm going to go on to clinical vignette number 3, and
Okay,
this is a
I'm happy to
female
try to call him from the
participant who
office
just
here.
had.
However, if you were having trouble,
Hi,
my guess is
somebody's
that I
talking.
will as well. And
I
what
can
should
hear
I tell him
you.
is the reason that you can't meet with him today?
Oh dear. All right, I'm not sure who it is. There's a few people that are not muted.
Yeah. They're getting ready to maybe hang up.
Right. Well, he's probably driving, like I said, if he's on his way here. So
sounds like Bonnie Perry.
I
maybe.
think that maybe we should leave it at that. I assume that he'll receive your message and.
Let me see if I can mute her. Oh, there we go. Let's try that. I think that worked. Oh no, darn it, it didn't. All right. Clinical vignette 3 is a female participant. Recent loss of second son. 2 sons have died within 4 years of each other. And this participant has informed the SASH coordinator severely depressed. And she doesn't believe in talking to anyone. Doesn't socialize, doesn't come out of the apartment, will not discuss with the primary care, but however has confided with the SASH coordinator. So somebody has an in there.
Yeah, I will try to call him again, but if I get through, I'll let him call you. And
I know.
Two kids within 4 years of each other is, very understandable. First, I definitely would want to be, I would hope that someone's asking her about suicide. So that's always going to be my first question, especially with severely depressed. And I guess I'd be curious what her life looked like prior to the son. Like, are we seeing a rapid decline, or has this sort of always been, an issue? Has she never socialized? Has she never come out of the apartment, or have these events really pushed her into that depression? I think the relationship is always going to be key. So I think that service coordinator definitely has the ability to probably have some ins and make some changes. And so what would be the minimal that this client would be willing to engage with the service coordinator outside the home? And I think that might be a good idea. You've got to, do something together, but still with a challenge. Except where she's at, push for change. I think is going to be key. Yeah.
That's a nice mantra. That's where she's at, push for change. Nice. Yep. Perfect.
And this is Haley Williams calling from the SASH office.
I also think
just a few minutes before 9:30, and we just got a call from Barbara Frechette here at the courtyard. That she had tried to reach you a bit earlier this morning, but that she wasn't able to get through.
I always think it would be nice to partner around,
for some reason, she wouldn't share
generally
that
around the free
she wants you to call her directly if you could.
Because
and
we all age,
I'm sorry for such a last
pass, or,
I'm sure
all this loss in our life. So just to normalize it, I also think we're a culture that doesn't talk about grief enough, and I think people tend to shut down a lot when it comes to grief.
I did let her know that
2 weeks of people
you were on
bringing
your way
food
here and unable to phone,
people,
answer
and
the
then
phone
sort of end.
because you were driving.
So how do we continue that? Grief lasts longer than 2 weeks.
She was
So I just think talking about that more is helpful.
Today, and for some reason this morning
Great.
Not. So just wanted to pass that along. And,
all right. Let's go to the next slide then. Thank you very much, Julie. Great advice.
Absolutely. Yep. That's it.
That's it. So if you guys have any questions, you can always email me, and I can shoot an email over to Julie, and I will let the nurses know about what we are doing in March. We are going to do a little online education class, and I will send information out about that. And with that, I want to thank everybody for a great attendance today. You all have been unmuted. And Julie, thank you so much for coming and speaking with us. It was a great webinar. Thank you.
Absolutely. No problem.
All right. Have a great weekend, everybody. Take care.
Right. Thank you. Bye-bye.
Bye.
Good week.
Bye. Bye. Thank you.